Good evening, everybody. My name's Catherine. I'm one of the community advisors at MS Auckland. We've got an exciting event tonight. Dr. Benson Chen is going to share his knowledge on the fascinating world of how optic neuritis is involved in multiple sclerosis. He is a neurologist and a research fellow at Auckland University. So whatever you learn tonight, prize it. Okay, I'll hand you over to Dr. Benson Chen. Thank you.
Thank you so much, Catherine, and what a pleasure it is to be able to talk to you all tonight about optic neuritis and MS. So I'll just bring up my slides and let's get straight into it. Right, so let's just put that into, there we go. All right, so as Catherine said, I'm a consultant neurologist at Auckland City Hospital and also work as a neuro-ophthalmologist, and we'll have a chat about what neuro-ophthalmology is a little later on, but I also have a joint appointment at the University of Auckland as a senior research fellow. So for tonight's webinar, I'm going to be discussing optic neuritis and how it relates to MS. And specifically, the objectives of the presentation tonight are to cover, firstly, what is optic neuritis, have a think about how we might make a diagnosis and treat optic neuritis, and what's the visual prognosis, so what sort of recovery do people make after optic neuritis. And then finally, we'll have some time to discuss some practical tips and suggestions for people with MS about what to do if you think you've got optic neuritis or other symptoms related to MS. But to begin, to introduce the case of optic neuritis, I think it's worthwhile illustrating a presentation that might be very familiar for some of you watching this webinar. So the case I've got here is a 23-year-old woman who developed a blurred spot in her vision in the right eye on a Sunday morning. By Sunday night, the fuzzy spot had grown bigger. She also noticed some discomfort around and behind the eye, which she described like a pressure feeling. It wasn't particularly painful. It was like a heaviness sort of around the eyes associated with a headache, which felt worse when she moved her right eye. She thought maybe it was because she was staring at her phone for a bit too long, or maybe it was the early onset of a migraine. So she didn't do anything about it because it was a Sunday night. The following morning, Monday, the spot was still very blurry in her vision and she couldn't read clearly at work. And the pain was still there, so she decided to stop by Specsavers on her lunch break. And so here's an example of what this patient was seeing with her right eye. And as you can kind of imagine here and see here, it's sort of very fuzzy, blurry spot in the middle with this sort of darkish grayish bit, which may vary for some patients. It might be just a very blurry spot, or for some patients, it might be very dark or very black, as we can see in this example here. So back to our case, the optometrist at Specsavers was concerned that our patient had optic neuritis, so she was referred to the eye clinic. And on examination at the eye clinic, she was found to have a visual acuity of 624. So that means that she's got reduced clarity of vision in her right eye. She also had reduced color vision in the right eye as well, and had difficulty recognizing the numbers in the Ishihara test book. And she was also found to have a right RAPD, which is a sign that we see in patients where there's dysfunction of the pupil and the pupil doesn't react as well to light. On visual field testing, so mapping out the area that she could see in her vision, she was found to have a central scotoma, so a big spot that corresponded to the blurry or fuzzy spot that she had in her vision. So she was subsequently diagnosed with optic neuritis, and the ophthalmology team discussed treatment with her, and she decided to go ahead with steroid therapy. Her vision improved a little bit after the first dose, but by day 3, her vision was much better, and the ophthalmology team were happy to discharge her home with a course of oral steroids for another 11 days. The ophthalmology team arranged an outpatient MRI for her, which was performed a month later. And by now, her vision was about 95% back to normal. A week after the MRI was performed, she got a phone call from the ophthalmologist telling her that they had referred her for neurology review. And 6 weeks after that, when she was seen in the neurology outpatient clinic, she was advised that the scan had showed some demyelinating lesions, and she likely had a diagnosis of multiple sclerosis. So what is optic neuritis and what does it involve? The first thing to recognize is that the optic nerves is essentially the electrical cable that connects the eyeball to the brain, as we can see in this diagram here. Although we often think about the optic nerve as part of the eye, the actual tissue of the optic nerve is really the same as the tissue in the brain. So the optic nerve is an extension of the brain itself, and as a result, is vulnerable to attacks from multiple sclerosis in the same way that other parts of the brain or the spinal cord might be involved with MS as well. And so often the patients that I see might sort of have difficulty understanding where the optic nerve is. Essentially, it's these bits here. So the bit that's behind the eye. So in this cartoon, you can see where the wolf's eyes are bulging out of the eye sockets. The optic nerve is this sort of stringy, cabley bit behind the eye heading in towards the brain. So how do we diagnose optic neuritis and how do we treat it? So the way that we diagnose optic neuritis has changed in the last 20 and 30 years. Historically, we would diagnose optic neuritis based on clinical information. So some of the typical features that we would see with optic neuritis are that it generally affects women. So there's a sex ratio of 3:1, so more likely to occur in women. And it tends to occur in younger people, so a mean age of 32 years of age. The vision loss from optic neuritis typically only affects one eye at a time. Sometimes it might affect both eyes, but it would be uncommon or very unusual for both eyes to occur at the same time. The other thing that's very typical of optic neuritis is that it's associated with orbital pain. So this is pain around the eyes. The pain's usually only very mild, and the pain has been described as being worse with eye movements. So by that, I mean if you're looking from left to right or up or down, just with your eyes only, you might feel that the discomfort from the pain of the optic neuritis around the eyes feels slightly worse. With regards to vision, we understand that optic neuritis typically causes reduced contrast in color vision. So patients or people affected by optic neuritis will describe alterations in their color vision, particularly colors don't feel as bright or as in contrast. And reduced contrast vision refers to the ability to perceive colors of very different, colors of similar shades. So for example, looking at something sort of gray or lighter colored on a white background might be really difficult for someone with optic neuritis. Finally, the thing that makes it very challenging to diagnose optic neuritis clinically is that often when we examine the eyes and the back of the eyes themselves look normal. And that also includes the appearance of the optic nerves. And I'll show you a picture of what that might look like. The other thing that we recognize about optic neuritis is that the visual prognosis, so the recovery, is generally good, even without treatment. So in the last 5 years, there's been a big push towards using more investigations to try and confirm a diagnosis of optic neuritis, because optic neuritis is one of these diagnoses that are made in excess. So often people will be misdiagnosed with optic neuritis, and that obviously can have ramifications for, making a diagnosis of MS or deciding whether or not we need to escalate disease-modifying treatment or management in MS as well. So in the eye clinic, we've got a number of tools that we can use to help us determine the severity of vision loss in optic neuritis and help us to make a diagnosis as well. So to help us determine whether or not vision loss is severe or mild, we carry out a number of tests. And many of you watching this webinar would probably experience some of these tests because they're often performed when you go to visit your optometrist or optician, and it's actually very easy to sort of access these investigations as well. So when we're assessing visual function, some of the things that we might want to look at include visual acuity. So this is someone's ability to read a letter chart. We might perform a visual field test, and this is usually performed with a special machine that maps out the area that someone might not be able to see as well. So in this example, we can see that this person with this eye over here on the right side of the picture, they have constriction of their visual field. So the area that they are unable to see seems to be in the periphery. So this is what we would often call sort of a tunneled vision. The other test that we can sometimes do to detect problems with color vision is to perform an Ishihara color test. So this is a special book that has lots of patterns of numbers, as you can see here, made up of individual little dots of different colors. And depending on what pattern it is, we can try and determine whether or not someone has reduced color vision as well. Modern imaging technology in the eye clinic allows us to be able to visualize the optic nerve at the back of the eyes. So through the pupils, we can actually photograph the back of the eyes. And in this diagram here, where you can see a photograph of someone's retina with their optic fundus, this little circle here that's shaped like an egg with the blood vessels running out is actually the optic disc itself. So we can actually visualize the optic nerve. In optic neuritis, around 1/3 of patients will have a slightly swollen optic nerve. But for the vast majority of patients, so 2/3 of patients, the optic nerve will appear entirely normal. We also have access to special technology which allows us to measure the thickness of the optic nerve and the fibers that are coming off the optic nerve. And so here's an example of what we call optical coherence tomography. And we can see the individual layers of the retina, and the inner layers, this white section here represents the fibers that are coming off the optic nerve and essentially connect the retina from the brain to the brain, sorry. The other thing we can look for is to look to see how someone's pupils might be able to respond. And this is what we call a swinging flashlight test. And the goal here is to shine the light on each eye in turn and to watch the reaction of the pupils. In someone with optic neuritis, the pupil reaction might be a little bit sluggish, or when you're swinging the flashlight between each eye, the eye which is affected, instead of constricting, we might notice that the pupil starts to dilate instead of reacting very, very quickly. Ultimately, the diagnosis of optic neuritis can be made clinically, but often we like to confirm the diagnosis using imaging. So for example, MRI of the orbits, as we can see here. So in this diagram, this picture shows a patient with an optic neuritis affecting their right eye. And this diagram, which is a cross-section through the eyeballs and the eye sockets, here you can see their right eyeball, and here is their left eyeball. And this string or cable that connects the eyeball to the brain is the optic nerve. The difference between the left optic nerve here and the right optic nerve, as I hope you can appreciate, is that the right optic nerve looks brighter, it's thickened, and there's some enlargement in this section here, which essentially confirms the optic neuritis. So, how do we treat optic neuritis, and what do we know about the treatments? So a lot about what we know regarding the treatment and the prognosis of optic neuritis comes from a multi-center clinical trial performed in the late 1980s and early 1990s in the US, and it was called the Optic Neuritis Treatment Trial. In this study, they enrolled over 400 patients presenting with optic neuritis and randomized them to receive either 3 days of high-dose intravenous methylprednisolone or a moderate dose of oral prednisolone, and then followed them up over a maximum of 6 months' time initially to see what the level of recovery is after optic neuritis. In the ONTT, the optic neuritis treatment trial, they found that treatment with 3 days of intravenous methylprednisolone hastened the recovery of visual outcomes, but it didn't affect the ultimate visual outcome. 3 days of IV methylprednisolone was also superior to the moderate dose of oral prednisolone. So many of you watching this webinar who have had optic neuritis may recall needing to go into the eye clinic and receiving intravenous methylprednisolone for optic neuritis. It's really important to note that the ONTT also taught us that visual function recovers within the first 2 weeks after onset of optic neuritis, irrespective of whether or not people receive treatment with the methylprednisolone, the moderate dose of oral prednisolone, or no treatment at all. Most of the recovery after optic neuritis occurs by the end of the first month, and further slow recovery then may occur over several months and sometimes up to a year. In the ONTT, we also learned that the risk of experiencing a second neurological event and developing definite MS was related to the presence of lesions on an MRI. So this may not necessarily apply to the audience watching this webinar, because the participants of the ONTT were people who didn't have a known history of multiple sclerosis, but had presented with a first ever attack of optic neuritis. And they found that over a 15-year period, the risk of developing MS and a second neurological event was 25% in people who had optic neuritis, but no demyelinating lesions on their MRI at the time of the optic neuritis. But for people who did have optic neuritis and were found to have at least one lesion on an MRI, their risk of having a second neurological event and developing definite MS was 72% over 15 years as well. So in other words, we know that optic neuritis is strongly associated with MS, and the data shows us that over 70% of people with MS will experience an episode of optic neuritis at some time point. And for 20% of people or thereabouts, optic neuritis is the first presentation of MS. So let's have a think about visual prognosis. So as you've heard me say already, the visual prognosis after optic neuritis is generally quite good. The severity of vision loss at the time of the attack seems to correlate with the visual recovery. So what this means is that if someone's had quite terrible or really severe optic neuritis, the chances of them making very good recovery later down the track is not going to be as good as someone who's had optic neuritis, but the optic neuritis was only very mild at the time of the attack. Even though the visual recovery after optic neuritis is generally good, common problems still occur after optic neuritis, including problems with glare and light sensitivity, problems with contrast sensitivity. So what this means, as I said earlier in the talk, was difficulty differentiating between something like this panel here on the right side of the screen, where you've got a gray lettering on a white background, whereas something that's high contrast, such as this black lettering on the white background, is a lot easier for people to see. And most people after optic neuritis generally won't have problems with high contrast visual acuity. The other thing that people also observe is problems with color desaturation, even after the episode of optic neuritis is finished. And here's an example of color desaturation. The apple on the left-hand side represents a normal color saturation, and someone who's had optic neuritis may notice that the red color isn't as bright or as sharp, and sometimes might appear a bit faded or even orange in color. People with optic neuritis may notice some fluctuations in their visual function after they've recovered from optic neuritis, and this is very much the same as other clinical attacks of multiple sclerosis. So some patients may experience a pseudo relapse, particularly if they're tired or stressed or have other illnesses, or if they overheat, they may notice that their vision starts to gray or fade, like an attack of optic neuritis. But usually after resting or cooling down or trying to address the factors that might have made their vision worse, the visual function will improve. So it's really important to make the point that these fluctuations in vision do not represent another attack of optic neuritis, but instead are likely to be pseudo-relapses. Finally, it's also important to mention that some people after optic neuritis may continue to have some difficulty with fine detail vision, or they may continue to experience a blur in different parts of their visual field, depending on which part of their vision was involved as part of their attack of optic neuritis. So let's talk about some practical tips and suggestions. So one question I often get asked is, who are the different people in the eye clinic, and who should I be seeing for me for my eye problems? I think the first group of people to recognize are the optometrists that we have working in the community. Optometrists are trained to diagnose and treat common vision problems and certain eye conditions. Optometrists don't undergo medical training, so aren't able to make complex diagnoses or offer complex medical therapies or surgeries, but optometrists have an excellent role for providing comprehensive eye examinations, prescribing glasses, and treating certain conditions. In the world of vision health, I often consider optometrists to be the first point of call, like you would see your GP for something that might be related to your health and you're not quite sure what it might be related to. Opticians, on the other hand, sometimes the word opticians is used interchangeably with optometrists, but opticians are not optometrists. Essentially, a licensed dispensing optician is someone who's trained to design, fit, and dispense glasses based on prescriptions provided by an optometrist or an ophthalmologist. In the hospital, we then have two specialists who deal with eye conditions. Many of you would know about ophthalmologists. So these are medical doctors who specialize in the diagnosis and management of eye conditions and eye diseases. But some of us undergo extra training, and some of us also practice neuro-ophthalmology, which is a subspecialty of both ophthalmology and neurologists, where we have extra training to diagnose and manage neurological conditions that cause eye symptoms, including vision loss. So,
I love you.
So the question here is, what should I do if I think I've got optic neuritis, or what should I do if I've got visual symptoms which I think relate to MS? So I think one thing I would encourage everyone to do is to first pay attention to whether or not the symptom involves one or both eyes, because this is often a question that the optometrist, the ophthalmologist, or the neuro-ophthalmologist might ask you when you're seeing them in the eye clinic. And the easiest way to do this is to cover up each eye in turn and to notice what you're seeing with your eye and whether or not the change in your vision is coming from one eye or both eyes. The next question to ask is, does the eye look any different? So if you look in the mirror, or if you take a selfie or take a photograph, does the eye look red? Does it look swollen? Is there any changes in the position of the eyes or the pupils or the eyelid? Another question to consider is the symptom associated with pain? Does the eye or the area around the eye feel painful? Does the eye sting or burn when you blink? Is there anything that makes the pain worse, such as pain with eye movements? And lastly, I'd like you to pay attention to what you can see with your eyes. Is it a problem with the clarity of vision, so not being able to read certain letters or numbers because the vision is blurry? Is there a problem with color vision, so noticing that things aren't as bright or as sharp? Or is it a problem with a visual field defect? So within the area that you can see, do you notice if there's a blurred spot or a fuzzy patch? And does that fuzzy spot or blurred patch change in size or move around? Why is it important? Well, often people living with MS experience a number of visual symptoms, and these might relate to double vision or nystagmus, so moving or spontaneous shaking of the eyes. The vision sometimes might shake. You might notice that the area that you can see is reduced, or the clarity of your vision isn't good, or that things aren't as clear or sharp depending on the amount of lighting or color vision that you have. Lastly, some people will also experience glare and light sensitivity as well. It's really important to recognize that some of these symptoms might be related to MS lesions not involving the optic nerve. So MS lesions involving the visual pathways of the brain or the brainstem might affect the control of the eyes, leading to double vision or loss of visual fields. Some of the symptoms that people experience might actually just be related to eye condition. So dry eyes is a very common eye condition, which might be exacerbated by MS. So for example, dysfunction of sensation on the face or the surface of the eyes might lead to the surface of the eyes drying out and causing visual symptoms. So it may not necessarily be optic neuritis. The other thing to consider is that some of the visual symptoms might be related to treatments that people are receiving for MS. It might be related to complications of disease-modifying therapies or steroids. So the big take-home point here is that although optic neuritis is a common symptom of MS, not all visual problems in MS are due to optic neuritis. So what should you do if you've got concerns about your vision and you think you might have optic neuritis or a complication of your MS? The first group of people I'd encourage you to talk to would be your optometrist, or if you already see an ophthalmologist regularly, mention to your ophthalmologist that you're having problems with your vision. Your optometrist might be able to check to see whether or not your glasses need updating. The optometrist and ophthalmologist can also check if the surface of your eyes are dry and if you need lubricating treatment. They may also be able to check whether or not you may have glaucoma or cataracts, because glaucoma and cataracts are often associated with prolonged use of steroids, which are often a first line of treatment for acute exacerbations of multiple sclerosis. Another question that I would encourage you to all ask your eye specialist is whether or not the symptoms you're experiencing might be related to your MS treatment. If you're seeing a neurologist regularly, it might be worthwhile asking your neurologist whether or not your eye symptoms might be related to a relapse of your MS. But importantly, again, could it be a side effect of your MS treatment? And certainly, if your ophthalmologist or neurologist isn't able to assist, if they're in doubt, I'd really encourage you all to ask your specialist to refer you for a neuro-ophthalmology assessment. So before I sort of wrap up, I just want to present one more case. And this is why I think it's really important to think about things that might look like optic neuritis, but aren't. So here's another case of maybe optic neuritis. We've got a 54-year-old woman with a confirmed diagnosis of MS. She's on natalizumab or Tysabri and has been on it for a couple of years. She's JCV negative. She reports 2 weeks of blurry vision in the left eye associated with some eye pain, which is worse with eye movements. There's a previous history of optic neuritis involving her left eye, and her MS disease activity is otherwise stable on Tysabri. She hasn't had a relapse for several years, and her MRI scans, her last one, didn't show any new interval lesions compared to the scans that had been performed previously. On her exam, her visual acuity was 6.6 in the right eye, so that's the better eye. And in the left eye, she had a visual acuity of 6.38. She also had reduced color vision in the left eye and a left RAPD. So in this picture here, this is photographs of the back of the patient's eyes. This is a photograph of her right eye where we can see the optic nerve. And in the left eye here, we can see that the optic nerve looks pale because she's had optic neuritis before, and it looks a little bit swollen. So this patient actually went on to have treatment for optic neuritis. She received intravenous methylprednisolone, but her vision got a lot worse and she lost vision quite quickly after treatment with methylprednisolone was started. So this patient actually didn't have optic neuritis. So here we can actually see the full photographs. The right eye, which is the picture here, panel A, shows that normal appearing optic nerve with a normal appearing retina. But here in the left eye, I hope you can appreciate that in the periphery of her retina, so out here at the edges of the retina, it's now gone white. So she's lost blood supply to the retina, and there's also bleeding, and the blood vessels have become inflamed, and she's essentially lost vision because of this retinitis or inflammation of the retina. So this patient has a diagnosis of progressive outer retinal necrosis with the acronym PORN, and it's due to infection caused by the chickenpox virus or varicella zoster virus. And this is a patient, of course, who's been immunosuppressed with natalizumab. So the big learning point here is that people who are taking immunosuppressive or disease-modifying therapy for their MS, be very wary if you notice changes in your vision and you're given a diagnosis of optic neuritis, because in your immunocompromised state, you're much more vulnerable to infections that can cause loss of vision due to infection or inflammation of other parts of the eye. So this warning slide here is really mainly to remind doctors that in people with an established diagnosis of MS, don't assume that visual symptoms are due to optic neuritis. So if you've got visual changes that occur in both eyes and in the same part of the visual field in both eyes, it might indicate a new demyelinating lesion. So it might actually be a relapse rather than optic neuritis. It might be due to infection, so in immunosuppressed patients, as we saw before. Patients who are taking steroids for a long period of time may be at risk of developing glaucoma or cataracts, and glaucoma can cause progressive vision loss, and cataracts can also cause the vision to become blurry or clear or cloudy. As we know, patients on Tysabri, particularly if they are JCV positive, might be at risk of PML as well, and this may also lead to visual changes. Certain drugs can also cause ocular complications. So fingolimod, also known as Gilenya, tend to cause fluid to build up in the back of the eyes, so a condition called macular edema. And in other parts of the world where this medication alemtuzumab or Lemtrada is available, it can also cause problems with thyroid eye disease as well. But currently alemtuzumab is not funded by Pharmac in New Zealand. Some of the other questions that you might be thinking about watching this webinar are, is there anything I can do to make my vision better after optic neuritis? So unfortunately, glasses don't improve vision after optic neuritis. It's a damage to the optic nerve, and glasses are unable to improve that vision. However, it may be worthwhile getting your prescription updated with your optometrist or optician if you haven't had your glasses updated in a while. If you're experiencing glare and light sensitivity after optic neuritis, these can be managed with sunglasses, special filter glasses, for example, FL41 lenses, which some opticians are able to prescribe or dispense, and simple practical things like turning on the blue light filter or putting your electronic devices into night mode might also help with that glare and light sensitivity as well. There's also been a lot of interest in using things like optic nerve electrical stimulation or vision restoration therapy to recover the optic nerve after optic neuritis, but certainly there hasn't been any clinical trials demonstrating the efficacy for these treatments. So this isn't something I would routinely recommend to patients that I see. Finally, for some patients, low vision clinic and visual rehabilitation might be useful, and the best way to access these services is through your ophthalmologist. So as I've talked about, optic neuritis, although we do know a lot about it, there are actually a lot of unanswered questions that we have. So these are really good opportunities for us to research optic neuritis in more detail. One of the questions that you might think about are there factors that can predict who will recover from optic neuritis and how well that recovery might be? Or can we predict who might have recurrent episodes of optic neuritis? Are we able to tailor optic neuritis treatments for different people? And the question that I think is most important is actually, what is the impact of optic neuritis on vision-related quality of life in people with MS? Although from the big studies, we understand that visual recovery is generally quite good, I know that many of the patients out there watching this webinar may experience daily challenges due to vision problems after optic neuritis, and we don't really have a handle on the extent of the impact of optic neuritis and how it might affect someone's day-to-day functioning. So to answer some of these questions, I've recently returned from the UK to join the University of Auckland, and we're setting up some research studies with the support of the Neurological Foundation to investigate optic neuritis. And this is work that I'll be completing with Professor Helen Dinesh-Meyer at the medical school. So with that, I'd like to say thank you for your attention. This is the first webinar that we're doing on visual symptoms in MS. Early next year, we'll do the second webinar exploring other problems that can cause visual symptoms, including problems with double vision and control of eye movements. And with that, I'll say thank you, and I'm happy to take questions.
Thank you so much, Benson. Thank you. What an informative webinar you presented. Thank you. We've got a couple of questions. One of them is, can a trauma to person's head that resulted in a burst vein in the eye, could that be related to ON?
Yeah, so for optic neuritis, I think it's very unlikely that a burst vein or head trauma might lead to optic neuritis. Usually when bleeding occurs in the eye, it's very much localized. But, there are some theories that there perhaps, may be things that trigger off attacks of optic neuritis that we don't fully understand. So I don't think there is a direct correlation or link there, but this is an area that a lot of people are interested in. Some types of head trauma, particularly if they are very severe head trauma, can lead to a separate condition which we call traumatic optic neuropathy. So this is when the head injury is significant enough that the little fibers that make up the optic nerve essentially get torn or injured, and that leads to an optic neuropathy, so a condition where people can lose vision, but in itself it's not really an inflammation of the optic nerve like optic neuritis is.
Thank you so much. We've got multiple questions about your research and whether you need volunteers.
Yeah, so I really appreciate everyone's enthusiasm for optic neuritis research, because visual problems really is a big problem, I think, for people living with MS, and vision plays such an important role in determining our quality of life. So I think if you are interested in participating in our research, I'll have more details which I'll forward to the MS Auckland team, and they'll be able to advertise it as well. We haven't necessarily set up the studies just yet, but it will involve potentially inviting people to come in and have their optic neuropathy or optic neuritis examined and follow them up over time to see what happens with their vision and whether or not there are any clues or signs as to how people might recover. And one really exciting area that potentially we can sort of explore further is looking at remyelination therapy after optic neuritis, where we can use certain medications to help try and grow back or recover the myelin that's been lost as a result of optic neuritis. And there's potential therapeutic benefits there in helping people improve or recover their vision.
Fantastic. Thank you so much. Is it normal for the pain to get worse when you're tired and stressed?
Yeah, absolutely. So pain can be quite a common problem, or ocular pain can be quite a common problem for people living with MS, and it might be for a variety of reasons. So generally, the pain that occurs after optic neuritis will usually settle down as the inflammation from the optic neuritis settles down. Any residual pain or discomfort, particularly pain or discomfort that's around the eyes or on the surface of the eyes, especially if someone's tired, might might be due to other eye conditions such as dry eyes. So dry eyes, although we often don't necessarily think that we've got dry eyes, because everyone's sort of using electronic devices such as their phones or computers these days, one thing we have observed is that our blink rate actually reduces when we're using electronic devices. So our eyes actually have a tendency to dry out. Certainly, if you're using the computer a lot for your work, you may also notice that as you get tired, the vision will get worse and the eyes will start to ache. And so it might be worthwhile getting your eyes examined by an optometrist to see whether or not there's any dry eyes. Or a simple solution might be if the eyes are achy, particularly after using the computer or after a long day, you can easily purchase some lubricating eye drops over the counter or in the supermarket without a prescription that you can try to see whether or not that might sort of ease that discomfort or pain that's there.
Great, thank you so much. Another question, if you have MS but never experienced ON, will you get it at some stage?
So the older studies that were done looking at the frequency of optic neuritis in people with MS reported that around 70% or over 70% of people experience optic neuritis at some point in their life. I think, you know, we've now got access to fantastic medications that reduce the risk of having relapses in MS. So for people who are, you know, are on disease-modifying therapy, I think the risk of developing optic neuritis would be very, very rare or, you know, less common. If someone isn't taking disease-modifying therapy, there is obviously that risk of having optic neuritis. The good thing is that we do consider optic neuritis as a site for demonstrating a clinical relapse. So if you do experience optic neuritis and you haven't been started on disease-modifying therapy, please let your MS nurse or neurologist know because potentially they can apply for you to have access to disease-modifying therapy if you also have experienced a relapse previously elsewhere as well. One thing that is really cool and exciting, and I didn't really talk about it, but I showed you in the presentation, we can do imaging of the nerves and the optic nerve at the back of the eyes, and there's increasing interest in measuring the thickness of the nerves and using that thickness as a surrogate measure for whether or not there's been any previous optic nerve damage. So for people who may not be aware of whether or not they've had optic neuritis in the past, we can use special imaging in the eye clinic, and some of the optometrists are even able to do it themselves, demonstrating whether or not someone's had previous damage to the optic nerve. And depending on what the pattern of that damage is, it may also be evidence that perhaps someone's had optic neuritis in the past, and either they've forgotten about it because the symptoms were very mild and they recovered from it really quickly, or they may not have even been aware of it themselves.
Thank you so much. Another question, what are the chances of ON reoccurring and or happening in the other eye?
Yeah, so optic neuritis occurring in the other eye is also a risk as well. I don't have good data to give you a percentage of the risk of that happening. But again, I think it relates to the last question. If you are on disease-modifying therapy, is very sort of unlikely that you will experience a relapse. The risk of optic neuritis essentially would be very similar to the risk of having a relapse involving any other part of the brain or the spinal cord while people are on disease-modifying therapy. I think the challenge and what I was trying to sort of convey in the presentation today is that often in people with a diagnosis of MS, if you talk to your GP, an optometrist, or even your neurologist or ophthalmologist, if you mention that you've got visual problems, often people will assume or jump to the conclusion that you're having an acute attack of optic neuritis, when in fact it might be something else. Optic neuritis is one of these things that's overdiagnosed and often misdiagnosed, and even people who have, say, migraines, for example, where you have a headache or a pain that's around your forehead or your eye, and you've got a visual aura where the vision becomes very sparkly and lasts for a couple of hours, or it might last a day, and the vision gets sort of very blurry and faded. Sometimes patients who have migraines with visual auras get misdiagnosed as having optic neuritis. And particularly, you know, when the MS cohort, well, when people with MS tend to be quite young, there's often that confusion as well. So definitely do talk to your optometrist or your ophthalmologist. And certainly if you're not satisfied with the explanation that they've given you or provided, and there's any concerns or doubts from the specialist that you're seeing, then I think asking for an opinion from a neuro-ophthalmologist would be worth your while.
Thank you so much. I think we've got some other questions, but they're quite specific. So I think that's all, unless, Catherine, do you think any other questions are relevant for tonight?
Well, I think that has been quite amazing and an all-round sharing of knowledge. It's been wonderful, really informative. Thank you, Dr. Chen.
You're more than welcome.